Hello, my name is Sebastian Champagne, and I'll be presenting my leadership project. So the title of my project is a stepwise entrustment pathway for SRNA's ultrasound-guided vascular access, from peripheral IV to central line venous catheter. So what we are here to do, we are here to fix a critical gap in how we train our future nurse anesthetists, specifically regarding vascular access. Right now, our approach to teaching SRNAs how to play central line is inconsistent. We rely on a variable level of trust rather than a standardized progression. I am proposing a stepwise entrustment pathway. This is a policy change that mandates mastery of ultrasound guided peripheral access before a student touches a central line. So let's be honest about the current state. So clinical opportunities for SRNAs to place central lines, those are hit or miss. Why? Because preceptors are hesitant to hand over the needle for a high-risk procedure to a novice, and they are right to be worried because recent data have shown about 3% of CVC placement result in a major complication. This includes arterial puncture, also pneumothorax. While that number sounds low, in a high volume center, that is significant patient harm. Currently, we often throw students into a CVC attempt without verifying that they have the requisite in-high coordination with an ultrasound probe. We are training by luck of the draw rather than design. So what is the solution? Here, what I am proposing, well, we need to formalize a stepwise entrustment pathway. We move away from counting numbers of attempts. And what we move towards an entrustable professional activity, or also known as EPA. The policy is simple. So the SRNA, they must demonstrate entrustment, meaning that they can perform the task without direct intervention. So they will start an ultrasound guided IV first, and then from there they move to midline. They then move to peak line if they get exposure to it, and also move to arterial line, and also trickle in some regional as well, so they can get used to this ultrasound. And once they prove they can handle the probe and the needle safely on a peripheral vein, do they unlock the privilege to train on the central line? Each step reinforces the same fundamental needed for central line. Ultrasound image acquisition, needle tip control, vessel identification, cell technique, and complication awareness. So instead of jumping to the highest procedure, SRNA and entrustment progressively. The end result is the trust become earned and verifiable, not valuable. So why do we center everything on an ultrasound? So because the literature is overwhelming. For central lines, using ultrasound reduces the risk of arterial puncture and pneumothorax by a massive margin. Some data even suggests that there's an 80% risk reduction. And for peripheral IV, ultrasound increased the first pass rate to over 85 compared to just 32% with traditional methods. So ultrasound is no longer a nice to have, it is the standard of care. If our student cannot master the ultrasound machine, they cannot safely place line. So why start with the peripheral IV? So because the psychomotor skills are identical, the hardest part of vascular access is in the anatomy. It is the hand-eye coordination required to visualize the needle tip on a screen while manipulating a probe. If a student struggles to track the needle on the tip of the forearm vein, we should not let them near the internal jugular vein or the carotid artery. By mandating ultrasound-guided peripheral IV training first, we build a muscle memory in a low-risk environment. We create expert in vessel identification and needle tracking before the stakes get high. So how do we measure trust, right? Entrustment is based on objective performances. So each level has a checklist. Ultrasound optimization, consistent needle tip visualization, style technique, and ability to recognize in response to complication. So supervision is built in. We will implement a simple assessment tool where supervisors rate the student. Did they need my hands on the probe? And level two will be, or could I step out of the room? Level four, this is standardized, this trust. A preceptor knows that the student is EPA cleared. For peripheral, they process the verified manual dexterity to a table CVC. This reduces preceptor anxiety and increases student opportunity. And we define safety stop point as well. If the anatomy is challenging, the patient is unstable, or time becomes critical, the supervising provider takes over immediately. This protects the patient and protects the team. I'm pitching this as a departmental standard because it makes everyone's life easier and safer. So the preceptors, they get a clearer criteria and they have less uncertainties. SRNA, they get a fair and consistent pathway. Leadership gets better staffing development and reduced variation. From a change management standpoint, we built a small coalition of champions. We remove barriers like missing checklists or unclear expectation, and we aim for quick wins, early sign off, and improve first pass success at a lower level, starting from peripheral IVs, move on to midline, A line, regionals, and then we scale up to central line. So this project will allow us to measure what matters first. So what matters to us is going to be the first pass success rate, time to access, complication trends, number of SRNA achieving central line ready status, and a brief preceptor confidence survey. So what I'm asking for is an approval for a 60 to 90-day pilot with a designated champion. We have the equipment, we have the student, we have the evidence. I'm asking for your approval to implement the stepwise entrustment pathway. So let's stop trainings by change and start training by competency. Let's ensure every SRNA is a master of the ultrasound probe before they enter the high-stake arena of central line access. This isn't about giving SRNA more chances, it's about creating a safer, standardized system where competence leads to entrustment. Thank you. I'm happy to take any question.